Welcome to Hacking Hypermobility Podcast.
I'm Luna.
And I'm Shelly.
And we're two bendy mamas.
Hacking Hypermobility. All right. Welcome back to the podcast, everyone. And thank you for joining us today. So we've started talking about the journey into a medical evaluation for hypermobility disorders, including the Ehlers-Danlos syndromes and the hypermobility spectrum disorder. Those are abbreviated EDS, HSD, right? HEDS is the most common type we know, and about 1 in 500 people are already diagnosed with these conditions, although the true population prevalence is believed to be higher. Hypermobile humans and our connective tissue disorders can be seen on a spectrum of presentations, right?
Yes, Shelly.
Yeah.
It is a spectrum, and it's related to another spectrum. We'll get into that another time, though. But so in episode 4, we began explaining the current hypermobile EDS diagnosis. We talked about Criterion 1, which is heavily reliant on something called the Beighton score. Yep. And we went through the criticism with relying on this outmoded and limited system. In this episode, we're going to move through the next portion of the evaluation beyond just the hypermobility. We're going to break down Criterion 2, and then we'll move onto Criterion 3 of the HEDS diagnostic criteria in the next episode. These criteria were intended to also identify the signs of other rarer disorders. Once your care provider has determined that you have generalized joint hypermobility using that scoring system, they will move on to the second criterion to determine if your presentation has signs of more rare inherited connective tissue disorders. They'll work through your personal history as a means to rule out other things. So remember, HEDS is a diagnosis of exclusion. So first, let's give an overview of those next steps or criterion. So to meet the second criteria in the HEDS diagnostic checklist, you have to meet 2 of the 3 features explained. They're labeled A, B, and C.
Okay, so 2 of the 3, 2 out of 3 A, B, C. Okay.
Yep. So these features are related to your symptoms, your history, and your family history. So and if you meet 2 of these 3 features, A, B, and C, in Criterion 2, your physician will move forward onto the final and third criterion.
Okay. Well, so some of these features are subjective, right? So it's make sure you are working with a physician who has some familiarity with connective tissue disorders. So Luna, can you explain these? Because
let's give you like an overview of these, and then we'll talk about the details and explain the wording in this checklist a little more clearly for the general population. So this checklist is really written for medical providers, but we encourage you to read through it and go through it with your own personal history and make notes ahead of time for the evaluation so you're prepared. So we're going to go through and try to explain some of it so you can do that. So feature A of Criterion 2 evaluates the skin or the fascia signs, so the soft tissues, as well as pelvic floor concerns and marfanoid features. So pelvic floor being your lower abdomen, and marfanoid features being some certain physical signs related to another connective tissue disorder that's seen in others. It's called Marfan's. Feature B just goes through your family history with some key points seen in our histories. And feature C is related specifically to your presentation and ongoing nature of both pain and joint dislocations or subluxations, and ruling out other signs of the other inherited connective tissue disorders.
Okay. All right. So I have here my HEDS checklist that we did last episode for our homework. Okay, listeners, if you have yours, get that out. We're going to grade it now. We're going to continue. I'm looking through these terms. Yeah. So can you define some of those? Oh, yeah. Look. Yes. Ooh.
So I've got out my cool purple pen to grade work, but Shelly has a better pen for grading. What do you have?
This is, I just made a video about this yesterday. This is just foam, and I cut it to size, and now I have a fat pencil that I can
So
actually hold and maintain. I
that's
could write
awesome.
more than 2 sentences. Yes. Thank
So
you.
you have two extra hypermobility hacks for today.
Yep.
Shelly uses foam. I hold my pen in a special way. I write like this so that I don't write like
Right.
this.
Yep. And this stops me from doing that too.
So
So
when we grade your papers, we'll be careful.
yeah. So anyway, what does marfanoid mean? Because I've definitely heard that word before, but
Yeah. So it's
like,
just a medical term. It's an adjective describing some features, some
okay,
phenotypes, some presentations, generally to do with proportions.
okay,
Um, so it's an adjective describing these physical features common in another connective tissue disorder known as Marfan syndrome. It is another inherited rare connective tissue disorder. It also affects collagen, but in slightly different ways, and it's on the MFN gene.
okay,
People with Marfan syndrome have kind of a typical phenotype. Of course, it is a spectrum varying, based on how we look differently, different ethnic presentations, and that sort of thing. Most Marfan syndrome patients are tall and thin or thinner.
okay,
The thinness can be, that they do have a lower body fat percentage, but generally it could be just an illusion because they have unusually long arms, legs, fingers, and toes. Marfan patients' health can be affected as well. It can just be mildly affected or more severely affected. Its genetic causes are known. They know the genes. They can test for this genetically. One of the more concerning or severe things associated with this is the effect it may have on the large blood vessel that connects to your heart called the aorta. And that could even be life threatening. Like EDS, Marfan's is not always identified in childhood. Marfan syndrome features include that tall and slender build,
okay,
disproportionately long arms and digits. Another key sign is a sunken chest. So the breastbone, your sternum, that protrudes outward and then dips inward. They also tend to have some facial differences like a high arched palate and crowded teeth.
okay.
Frequently, they present with heart murmurs, and their vision is typically affected with extreme nearsightedness. They
Hmm.
typically present with an abnormally curved spine,
Y-
flat feet.
You okay? Can I? The whole time you're talking about this, I can't. I'm like picturing. I don't really picture things in my head because of the aphantasia, but you're making me think of Abraham Lincoln. Is that
Well, so you might
like the
be right.
tall, gangly, like
Yeah.
he just looked awkward and like out of
You, yeah,
sorts-ish.
you might be right. President Lincoln was not diagnosed with Marfan's, but people have speculated that.
Or like it makes me think of like
Um,
swimmers too, like
mhm.
the really
We
successful
won't name
swimmers.
names, but there's a lot of
No.
swimmers that have disproportionately long arms with good range of motion, and
Yeah.
yeah.
Oh. Hmm. Oh.
Um,
Have to
yeah.
keep an eye
So,
out now.
so funny story. I could share
Oh,
some
did you have
Marfan.
Marfans in your family?
I carry a Marfan allele, actually a couple. My dad carries more. So I inherited
Okay.
some from my father, none from my mother. There does appear to be Marfans on my dad's side of the family in both directions. And if you don't know this from being a fan already of hacking hypermobility, I love genetics, and that really came from my love of family history and genealogy. So everybody in my family always said my dad's dad, my grandfather, looked like Abraham Lincoln. Like, we have post family pictures, and people were like, "Hey, why is Lincoln with y'all?"
That's
And
funny.
not only had that been like a running joke that my dad's dad looked like Abraham Lincoln, but when I was doing the family history research, I found one of his ancestors, and he literally just looks like a carbon copy of him. And I'm going to try to share on the screen.
Okay.
So on the right, the younger man is my dad.
Okay.
He was always really tall and gangly. He's a little overweight in this picture, so it's hard to tell. But he was, I mean, that's kind of what he was known for. It was just being really tall and gangly. And that's his father, also tall and gangly.
Yeah, I can see it in his. I'm going to have to get some pictures of my cousin to show you.
And that's not the best picture. It's just probably like the one I could find like quickly of both of them.
Right.
But so anyhow, everybody like would be like, oh, they look like President Lincoln. Okay, so this was.
Oh, wow. Oh, wow.
It looks exactly like my grandpa, except with different facial hair. And so, like, when I shared it with my family, we all laughed because it looks like my grandpa, but
Yes.
also looks like Lincoln.
Yes, it has very a Lincoln-esque
Okay.
vibe
And then
to it.
on the other side of my dad's family, this is actually his mom's side. This gentleman was over 7 foot tall. And I don't know if you can tell from the photograph, this was the 19th century. That was very unusual.
Yeah.
And if you look at his hands, they're very disproportionate. If you look at his arms, his legs, his face, everything is really disproportionate.
Oh, yeah.
And I can tell in our genetics that we have the Marfan's gene going from both directions on my dad's side. Those are just some examples of, I expect those are my ancestors with Marfan's.
Yeah.
I have no way of diagnosing dead people.
Well, yeah.
But
Right.
if a matter of deduction in my dad's genetics, yeah, those are the responsible parties. So those are just some examples of like what we may look like.
Squirrel. Done
Squirrel.
that. Okay, so we squirreled. Back to this. So what of those features of Marfan is on the checklist though? Because they can't just.
Yeah, it's not everything because they are different.
Right.
And not every EDS patient has Marfanoid signs or all of these. But the Marfanoid things that are on the HEDS checklist are seen in HEDS or hypermobile EDS patients, maybe just not as severely. So you will see a lot of HEDS patients with these things on the checklist. Disproportionate and long arm span, wingspan. Your wings being longer than your height. Long fingers, of which Shelley and I both do.
Yeah.
My sweet baby zebra says I have witch hands, but she says they're bony, they're veiny, they never have any blood in them, and they're long spider fingers, and they're creepy.
Yeah. So I have witch hands too, Evie. Sorry, not sorry.
And they look like they don't have blood in them because I have Raynaud's syndrome, which non-diagnostic, but is associated and seen in many EDS patients. But the only part in that
part of the posse
was the long fingers. Other things that are Marfanoid include dental crowding, meaning your teeth overlap, you've had to have braces, you maybe had to have a palate expander, a high, narrow palate, so the palate arch, the palate is the roof of your mouth, is maybe, rather than being shallow and gently curved, it's high and narrow. Heart murmurs associated with MVP, not the most valuable player, a little scary, mitral valve prolapse. So this is your heart valves not being valvy enough. Dilation of the aortic root. And not to complicate matters, but you may not have all of those signs, and they can overlap with other connective tissue disorders. Those Marfanoid signs are associated with Marfan's, but can be seen in EDS and other inherited connective tissue.
Why keep this simple and straightforward?
No. But those are good indicators or signs that connective tissue is affected. Some of these features are seen in EDS patients, but they're not really diagnostic. They're just kind of like clinical indications or signs. They don't necessarily share all of the same other features either, but there's that overlap. So we may have marfanoid features, like, you and I have those long
Yeah.
fingers,
Yeah.
just with like less severity or not as pronounced. It's important though that your doctor does a thorough physical exam and history to separate out warning signs of a more rare inherited connective tissue disorder. I also think some of these overlaps created some stereotypes, some assumptions and bias that have led to some of us humans affected by hypermobility being misdiagnosed or not.
Oh, well, because
Um,
I think I know where you're going with
yeah,
this.
yes, you probably do, and it
Because
affects
I'm
me.
tall and slender, I fit the
Yes.
mold for like a traditional, not traditional, but tall and slender when you think of a heads patient. So are we all
So
tall?
that is the assumption by a lot of the medical
The
community
medical community, yes.
that is not fully aware.
The ones who think it's just a joint problem or you're extra bendy. They
Yes.
don't realize all the other stuff.
Right. So there is a common misconception that all EDS patients are tall and slender. And
Well, we just talked about marfanoid things, and what did we talk about that whole time? How tall everybody was.
yes,
So you see
but,
how that gets ingrained, right? Like you just hear
right.
that and then it stays.
Yeah. So
But
it's
that's
not really being tall and slender. It's not part of the diagnostic criteria. It never has been.
so,
In fact, some of the rarer EDS types are marked by shorter stature. Arthrochalagic EDS, kyphoscoliotic. A lot of them have stunted growth.
well, so
You
hold on, wait a second. Can we go back? How do you were talking about wingspan, but like you said, short people can have a messed up. How do you determine
so
the wingspan?
you can be short and have a long wingspan. Your wingspan is the measurement fingertip to fingertip with your arms outspread. I'm
Okay.
kind of short. I mean, I'm not tall, I'm not short. I have people in my family much taller than me. I have people in my family
Okay.
much shorter than me. I'm my height also varies
Well,
because of
time of
variable
day because of,
scoliosis.
right.
It always has. And people like my doctor's office be like, "This is weird. You were 2 inches taller last time." I'm like, "Yeah,
And
I
you're
know.
like,
It's
yeah,
a
it's
magic
fine.
trick I do." I'm usually about 5'4",
Okay.
but I've been measured at like 5'5" and down to like 5'3", and on a bad day, 5'2". It's
Whoa.
confusing. My wingspan, fingertip to fingertip, is 5'7".
Which is how tall I am. I'm 5'7".
Yeah. So that's considered marfanoid. So basically they just measure.
Okay.
Yeah. So what's considered marfanoid is your wingspan, fingertip to tip, spread out like you're flying. Is that equal to 1.05 of your height?
Okay.
That's considered disproportionate.
Okay, well then how do they figure out your fingers are disproportionate?
Also, a sign of this would be, were you in school and were you female presenting? And did you always fail dress code? Because
Yes, because of the stupid, like, look how long my legs
we
are.
can't wear short shorts.
Because our stupid
Because
arms
our
screw up.
arms are
That's when you would
so,
just hike your shoulders up.
yeah.
But then
I
they would,
also,
yeah.
when I got to a certain age, I was too embarrassed to wear short shorts because my thighs were chunkier and more muscular. And it was the 90s and everybody wanted to look like
That
me.
was when they were going through the waif skinny. Yeah.
Yeah.
Okay.
So then they also we talked about the long fingers.
Yeah, with the wrist thing that we did, I can
Yeah,
do.
so they will measure your finger length to see if they're disproportionately long. That's known as arachnodactyly, which remember how I said my kid called them spider fingers?
Oh, yeah. Arachno.
Arachnodactyly. Yeah.
Mm-hmm.
So what Shelley was just doing on the screen is what they call the positive wrist sign or Walker sign, and it
Yeah.
is
I'm gonna
medically defined. Both her and I have, and I'm chunky, I'm overweight, I have lipedema. Okay, and my fingers still go around my wrist. So most people's fingers don't touch when they wrap their fingers around the wrist bone, and that's around our wrist bone, like around the bone.
Yeah.
That, right. That, yeah. They either don't touch or they barely touch. Ours overlap. Now, in Marfan's, it's usually even more pronounced than that. Yeah. So they will look at the Walker-Murdoch wrist sign to see if it's your fifth finger and thumb overlap.
All right.
There's also the Steinberg sign, which is the thumb is positive if the entire thumbnail protrudes beyond the border of the hand. So that's the more severe presentation.
I don't think mine doesn't go all the way.
Mine?
No.
So mine is pretty, like, I could, if I push that joint, go far. But, like, I mean, that's manipulating the joint.
Yeah, I don't think mine goes. Mine's bent. Does it have to be straight?
No, I don't think.
I mean,
yeah, because a lot of people have like a hitchhiker thumb or whatever. Yeah, so yours doesn't.
Mine's not quite.
And mine are different. Like this side doesn't at all go, but my right thumb is very stiff. So those two signs are used to identify Marfan. So as you'll see from what Shelley and I just discussed, if you're watching us on the screen demonstrating, our Walker sign is pretty obvious, but you can tell our thumbs don't go beyond past our
they
palm.
weren't past. Yeah.
No.
In
a Marfan's, it's known that they go like that. You know?
Oh, wow.
So no, we come in a variety of shapes and sizes.
Good.
Many of us could be tall and slender, but some rarer types, may have inhibited growth. We may have curved spines that affect our height, like I was saying. And a common comorbid condition with EDS is a fat disorder, which is called lipedema. It's marked by an atypical buildup of painful fat that is particularly seen in your lower body, sometimes your arms, and it can't be shed with medicine's typical approaches to weight loss. And I was diagnosed with that as an adult after having bariatric surgery because I thought I was obese and they didn't screen me for this. And now I'm being managed for this. And it's
so
painful.
That doubly screwed you because you were already at risk for like malabsorption and like nutritional deficiencies. And then to do a surgery like that adds even more to it.
Yes. So we can talk about that another day.
Yeah. But
that just goes to show you how deeply ingrained
that stereotype
assumptions are that even a doctor specializing in obesity did not screen me and see the physical signs of a fat disorder. And now I deal with some challenging aspects related to that. And I am still, if you go by like weight and the BMI chart, I'm still considered overweight, but my doctor, who is a bariatric specialist and knows about lipedema, said, do not lose any more weight. You are underweight, but yet you wouldn't know that looking at me. And so we'll do another episode maybe about this specifically, because I think it's also a vastly misunderstood and unidentified, rarely diagnosed disorder with very dismal intervention options.
Well,
but there are.
Yeah.
The classic signs are you carrying your weight in your lower body, being pear-shaped, having a skinny waist, skinny face, skinny hands and feet.
LA face and an Oakland booty, as Sir Mix-a-Lot might say.
Having fat deposits that don't have the typical shape, and having columnar shaped like legs, and then like having rings around like where your wrist and your ankles start. So like you can look at my ankles and like it looks like it swells and then all of a sudden they get really skinny. And that area is one of my most frustrating pains. Like it's physically painful from the pressure, and it creates neuralgias, neurological problems.
So compression, do you wear compression socks a
Yes.
lot to help with that?
Yes.
Yeah.
So that's the biggest. And I also have POTS, and I do think that they, I can treat both of them that way. So at least
Yep.
there's that. But there is no cure. And fat is a connective tissue. And so obviously there's a relation. We do not understand it yet.
Yeah. So you also mentioned heart murmur, and I was recently diagnosed with a heart murmur, but I had never had one before. Does that mean they weren't listening before? Or how would you know? Like, did other doctors just miss it? Like, how do you know if you have a heart murmur besides what I just said, like someone listening?
So heart murmurs can actually be somewhat commonplace, and it doesn't always mean that there's something seriously wrong.
Okay.
But typically a doctor will tell you that they hear a murmur when they're like listening to your heart with the stethoscope, that little thing that they, put on your chest and then listen in, right? So there's really actually a variety of causes, okay? It's not just like a genetic disorder. In this case, it's when the valves are malformed a little bit, and so they hear the blood whooshing through differently.
Okay. So I was diagnosed with that heart murmur, and then my cardiologist, because I just got diagnosed with head, sent me for an echo, and they said maybe this is where the murmur is. It said I had slight minimal regurgitation in my tricuspid valve. Would that be my murmur?
Yes.
Maybe?
So a tricuspid valve is your heart valve, and it means it has 3 flaps.
Okay. 1, 2, 3, try.
So those flaps open as your heart beats.
Yep.
They whoosh the blood in. They close. They whoosh the blood in again. Okay. So what's happening when they hear that is those valves don't quite close all the way, or maybe instead of having a tricuspid valve, meaning 3 floppy things, you only have 2, and so it doesn't close real well. It could also change over time.
Okay, which is why I had never
identified. I now have a whooshing sound that I never had before because my aorta has dilated, meaning that tube, that blood vessel connected to my heart.
That's on this checklist too. The dilated. Yeah. That's okay. So what is that what you were talking about just now?
Yes.
Yes. Okay.
So a dilated aortic root is when the blood vessel that's attached to your heart has a bulge near the valve that pumps the blood. So it's basically like that tube that connects to where the tube connects to your heart. That's where the valve is. Okay.
Okay.
So if that blood vessel has widened over time, dilated, expanded, now those valves are being pulled apart. They don't grow bigger. So now the seal may not be fully functioning.
Oh, like if you stretch a rubber band just a little too far and you get that little.
Yeah.
Okay.
So your aorta is the biggest, largest blood vessel in your whole body. Okay.
How big is where aorta? I always imagine it's tiny.
It's a honking big blood vessel. It's big.
Yeah. I just always imagined it as being tiny because I think of my heart, but it goes like it's in your whole trunk, right? It's like
and it arches down and goes it goes through the middle of your body.
Okay.
So it's this large blood vessel, and it feeds into your heart, right? So that affects the blood flow into the rest of your body, of course. That's why it's concerning. But if that blood flow is kind of slowed down there because of this widening, this dilation, the blood vessel stretches and bulges in one place. That bulge is that condition you may have heard of called an aneurysm.
Okay.
That's what an aneurysm is. So this condition is a risk in connective tissue disorders, including Marfan syndrome, Ehlers-Danlos, Loeys-Dietz. There is a risk that the aneurysm, that bulge, can create a blood clot. Okay. So that blood clot can travel, break free, and go to other organs and even burst. So that is why this can be so concerning. And this is a risk in the EDS variants, not just the vascular EDS variants, not just Marfan's.
So that helped me understand my grandmother. She had an aneurysm in her brain.
My grandmother did as well.
And they clamped it. So was that they just like pinched it off so that it wouldn't break free? Is that what
Yeah,
that meant?
they
I never
basically
knew when
just
they said clamped it. I'm like,
they
you
just
know,
they literally
probably just
stop the blood
cauterized
flow
it
there,
or
so it's
okay.
not gonna burst. And there are other health and lifestyle causes for these things, but yes, EDS patients, connective tissue disorders cause a much greater risk. Cardiovascular risk is our biggest risk, and that's why all hypermobile patients should have what you said you just had.
I just had it.
We
Yeah.
have, and my daughter has a cardiologist, and she's going to be screened for the rest of her life, same as me for this. It's called an echocardiogram. An echo, it's an easy procedure, right? You just had yours done.
Yeah, it was
Was it
pretty
scary?
easy. No, and it took
Yeah.
like half an hour, not even.
And
So,
speaking of Marfans, when my daughter went to the pediatric hospital that we go to,
yeah.
the echo tech, which is a great career, by the way, the echo tech was a Marfan patient, and he recognized us on the spot
That's cool.
because we tend to have certain
Features, right?
features. Yeah.
Hmm.
Yeah. Yeah.
So those features, skin features, we're going to be talking about now, right?
Yeah. That's what's
Is that
next.
what is that what maybe he picked up on? What are
I
so
think
those
so.
things?
Yeah, like those visible things. Yeah, so there's obviously serious conditions and things affected by connective tissue disorders. But some of the signs are superficial, these visual ones that we see. And this next part of the criteria, we'll talk about the skin features. So in addition to these features that overlap with Marfan syndrome, there are some additional signs and criteria too that are commonly seen in heads. And so the first thing we're going to look at are all these skin manifestations.
Okay.
Now, so let's dial back. What is Ehlers-Danlos syndromes? It's a variety of genetic mutations across all the recipes for collagen, right?
And collagen is in the
Skin,
skin.
which is our largest organ,
Yes,
and it's
people forget that that is
external.
an organ. It is an organ,
It
everybody.
is.
The
It is.
biggest
It's a
one.
very vital organ. It's external. It's what protects you from the outside world. It's sensory in nature. But so collagen is a structural protein. Okay.
Okay.
So
Like a Lego, like a building block, and it comes in different types. Like there's little Legos and big.
there's
You think
different
of
types of
collagen one,
Legos.
two.
There's
Yeah.
different types of collagen. There's different proteins that help build the collagen, that help support the collagen, that help the collagen interact between cells. It's a very complex thing.
Yeah.
It affects things like cell adhesion, cell communication, cell metabolism. It's very complex. And the
Yeah.
recipe for this is across many genes, literally. It's very interesting. It's very wide open research. It's not fully understood. But so the skin manifestations, therefore, vary across us, across
Yeah.
the hypermobile humans. They present differently in different types of Ehlers-Danlos syndromes, with the skin features being less severe in the hypermobile EDS type, but still there.
Yeah.
Um,
I have them.
yes.
You have
Therefore, the
them.
skin manifestations, being external and easily assessed, are very helpful in evaluating EDS. But, some of these features can be a little hard to visualize, and not every doctor knows these in and out, right? So they have to be
Right.
aware of these. So some of these skin features are hard to visualize. So we'll link to a few of these helpful resources in the show notes with visuals, photographs of patients. The first reference that I'll direct you to is a presentation from the 2019 Ehlers-Danlos Society Conference by the dermatologist, Dr. Nigel Burrows, Burrows, with some pictures and explanations of the distinct skin presentations across the different types and the differences between types. This is very helpful.
Ooh, yeah.
It's titled The Skin in EDS, and that conference was the Nashville conference, by the way.
Oh.
I
Did
was
you
not
go
there.
to it?
No.
Oh, because
Um,
yeah,
so
yeah.
the presentation has a helpful chart describing the skin differences between several of the more common but all rare different types of EDS. The second reference is a medical article from Dr. Castori, who we've mentioned before, with some pictures as well. The third one is a helpful slideshow presentation from Dr. Franco Manco, who we have referenced in our citations before.
Yep.
And this particular presentation is just about classical EDS.
Okay.
And then we'll share some of our own pictures and videos also.
Okay. So why don't we go over what some of these skin manifestations are in heads?
So the first one on the heads checklist is unusually soft and velvety skin. So this is a distinctly soft texture.
Okay. Is there a specific place? I know
yeah,
where
so
I'm really soft right here. Like this feels like a baby.
Yes. So typically they'll look at like your forearms. It's seen more severely in some other types of EDS. If your like skin is more doughy or like spongy kind of feeling.
Oh, that leaves the marks on, like socks that fit me, but then like I get these like big indentations and I'm like,
yeah,
why?
and I do too. Some of us have what's
so
called
that's a
skin
thing
writing.
part of it too?
Yeah. Some of us have what's called skin writing.
Oh, demographic where you can write and it pops up. Okay.
Yep.
Wow.
When my baby Zebra was born, the day after she was born, I was, you just admire your baby.
Yeah.
And I was like, what? Where are all these red marks on her? Is she okay? And then I realized it was just indentation from her onesie and blankie. And so I took it off of her. And I was like, oh my gosh, is she having a reaction? And then so I'm touching her bare skin and it's leaving welts.
Oh no.
And she was, sound asleep, perfectly calm. It obviously wasn't hurting her.
Yeah.
And I was like, guess I shouldn't be worried about this. But I could like write letters or shapes and it would stay there.
Wow.
And to this day, but then anyhow, I realized I have the same thing. But she was a baby. So like you're looking at the precious, unmarked, untanned skin.
Right. Like the freshest.
It was very, and it was just
possible.
Very noticeable. And I, of course, like my immediate panic was, oh my gosh, this poor baby's having a reaction. Why is her, like, who hurt her?
Oh.
No, she was fine. Perfect. So I have pictures of that too. It's just for day one, there were signs.
Mm-hmm.
Yeah. The next skin sign is mild skin hyperextensibility. That means skin stretchiness. Okay.
Stretchy
so
skin.
like stretchy skin is more pronounced in the more rare types. Skin hyperextensibility just mean that your skin stretches off of your body beyond what's typically seen in, non-connective tissue disordered people. In heads, it doesn't seem to be as severe as in other EDS types. But so this again is very subjective.
How do you know if your skin's stretchy enough?
So like this feature really has not been studied enough to have a lot of data to objectively measure. So again, this is subjective, but some practitioners will likely measure how far your skin pulls away from your body. And they'll do this they'll pinch your skin and pull it off of the hairless part of your forearm, the underside. Yep.
Under here?
And, like so where you said you're soft.
Oh, okay. So I don't have.
Or your wrist.
Oh, there it is. Okay.
Is it focused? I can't tell if it's visible.
And you can see mine too.
Yeah. And I'm wearing sleeves, so I don't know that I can. So the measurement. So I didn't think I had hyperextensible skin, which is going to be amusing to you when I do something else.
Oh.
But so the official measurement that they use, there's two. So the distal or furthest end of your forearms and the upper part of your hands. Okay. So this part right here.
Okay.
And then this part right here. Okay. If it goes more than 1.5 centimeters.
I don't know centimeters.
Which that's a half an inch.
Oh, I don't know.
Yeah.
Is it? That's a yes?
Yeah. Or on your neck, elbow, and knees.
Oh, my knees.
Okay, so my knees. Okay.
You can't see it unless you're
I
watching
thought I did not have
us on
hypersensitive
YouTube,
skin.
but
What
Luna
did I
is
just
stretching her
see?
eyelids and
I always
her
do
face
like
skin
the
and her
upper
neck skin. Check it
because
out.
that's just it freaks people out. But yeah, that's.
Oh, ow. That
I
doesn't
also
hurt?
like no.
That,
I mean, it kind of
I mean, it's
irritates.
uncomfortable.
It's not comfortable, but no, it does not hurt. It's not. It's not attached well.
I mean, yeah,
And
I
as
mean,
I've gotten older, I've gotten very self-conscious of like it kind. I feel like I'm melting.
you don't look
And
like you're
I'll,
melting.
yeah, and so we are blessed. Many of us in EDS have skin that either looks more wrinkly or younger. It's like one or the other.
So I've got a little bit of both. My face is young and my hands look like
Yeah.
I'm
My hands look
95.
like I'm 90.
Yeah.
My knees and my thighs.
Speaking of hands and 90, I just had that hand eval.
Yeah.
There's a hand specialist, and my grip strength
Like nothing.
My grip strength is 5 points lower. I'm 45. My grip strength is 5 points lower than the mean grip strength of women age 75 plus.
Yeah.
I'm
I
5
can
points
barely
lower.
hold on to my water bottle.
Yeah, that's
In
why
fact,
I got all of these.
what my mom got so mad at me one Thanksgiving because I dropped a pitcher of water. And that's like the last time I remember carrying like a heavy like vessel with liquid in it. I just don't do it anymore.
I like use
I
my forearm
can't.
and put it up to my
And
body.
I'm like muscle.
I know you're like weightlifter lady.
But I can't hold.
Well, that's why. So, and again, now
I can't open jars.
I've forgiven myself for not being able to ever do a pull-up or a push-up with my grip strength combined with my loose shoulders, combined with my loose elbows and wrists. Like it was never going to happen.
If I were to hang from a bar, here's what would happen. My elbows come apart, my shoulders come apart. But you know what feels really good? My spine.
Right?
My dad has one of those inversion tables for
I
spinal
want one of
decompression.
those.
He doesn't like me getting on it, but sometimes I sneak on it. If he ever listens to this, Dad, I'm sorry. That was me that made it shorter. But it feels so good.
Yeah. I just want to be like on a meat rack, or a big rack.
Yeah.
Like those torture racks.
In the rack. That does not sound like torture.
Well, whenever they showed that, I was always like, but that looks like it would feel good.
Right.
And then I was like, am I kinky?
Evelyn looks forward to going to school to sit in the chairs that hurt her back just right so she can pop in.
So
skin tricks.
Does everybody can do the skin tricks? Is that it's across all variants?
So skin hyperextensibility is not a universal human experience. It is a universal connective tissue disorder experience.
Okay.
This feature is seen in all EDS types at varying degrees, however, except VEDS or vascular EDS. However, I will caution you. My geneticist had a very hard time phenotype clinically diagnosing me, and they have not narrowed down a diagnosis for my child because of our mixed presentations. And guess what they discovered? I have mixed genetics. I'm extra stretchy because I carry one of the dermatopraxis EDS alleles, meaning I have half the recipe for DEDS. It's recessive, so you have to have both alleles, both partners, both recipes, codes from both sides. Me and my mom both have this.
Okay.
And luckily I got it too. I'll share a picture of me and my mom. We both look much younger than our age, but we both feel like we're melting. Like you can kind of tell our skin's falling off.
That is interesting.
But so, yeah, and skin hyperextensibility is something we pick up on visually, but may not have the words to describe or understand. So it can be seen in other places in the body, including a good example of this that Burroughs references is the skin around your eyes. So on your face.
Okay.
So not your eyeballs, not like eye health.
Because those have collagen also. Because
so these are not diagnostic alone, but are helpful. Some of these are just seen in
I don't
human
know.
phenotypes that are non-pathological. Okay.
Gotcha.
But if it's seen with
Pathogenic,
yes,
not pathological.
oh my God. So never mind. Anyhow, yes.
Okay,
Pathogenic.
just
Okay.
clarify.
So the first one that they reference sometimes is something called epicanthic folds, which is the fold of skin that is sometimes seen covering the inner corner of your eye. So
Okay.
I do not really have one.
Do I have
I
one?
will have Shelley put on the screen a photograph of my baby zebra who has pronounced epicanthic folds. But so it is seen in people of Asiatic and indigenous North American descent, as well as like Siberian descent. So like Asian looking eyes
Okay.
can naturally have epicanthic folds. So this can be confusing. That's why on its own, it is not diagnostic.
Okay, but if you have some of these other things and this, it kind of points to.
And I mean,
Okay.
I've made a video of this and I'll have Shelley link to it or show it on the screen. My daughter has epicanthic folds and she has both indigenous and Asian descent. I have West Asian and South Indian subcontinent ancestry. My sister has what we call the Asian eyes in our family. Some of us have Asian eyes, some of us just look like me. I don't have that. My daughter also has more indigenous ancestry than me, indigenous North America. So I don't know. It could be an ethnic thing, but it could be a connective tissue thing. The other skin sign around your eyes is called the Metenier sign,
Metenier. Okay,
which
Metenier
is
sign.
floppy eyelids.
Okay.
I'm gonna
Luna just flipped her eyelids.
do it. I used to do that for fun to freak out other kids.
Eyes gross me out. So like
I just thought that was a funny
me having
thing.
all
I
these
didn't.
eye problems. I've never actually tried that because eyes gross me out. I really don't like that my eyes
I'm
are
sorry
such a
I did that
problem.
to you. Then I
No,
should have
no,
asked.
no. It was fine.
The other one is ptosis, which I demonstrated earlier, the loose eyelid skin, hooded eyes.
Yeah.
You and I both have that. And again, that may just be for me an ethnic thing. I have a little bit of Asian, Middle Eastern ancestry. So I don't know. But also, it's pronounced in both of my parents on both sides of the family and on the sides of the family that are pretty European. And it does tend to be more pronounced with age, but be present even in childhood. So I can give a great tutorial on eye makeup for hooded eyes because makeup is one of my special interests and I have mastered hooded eyes.
I don't wear a lot of makeup, but I could use a tutorial on getting rid of like hiding some of my stretch marks. We get those too.
Yeah.
In weird places.
Unexplained stretch marks without significant weight changes in prepubescent females or men. And I mean biological, not how you identify. Okay. Seen on things like the back, in the middle of your back, your groin, your thighs, your breasts, and your abdomen. Now, my baby zebra had stretch marks before puberty on some of those areas.
I think so did my daughter. Now that I think about it.
Too, and I remember being very ashamed of them. And then I, of course, grew many more stretch marks as I entered, and I have a lot of stretch marks from like pregnancy and all that. But I have stretch marks all over my body in weird places. Not weird, but like I even have. You can see stretch marks, and like weird skin texture underneath my skin in my like neck, or not my neck, but like this part where there's like no fat, like kind of like under your collarbone.
Yeah.
Like there's nothing there. And I have just this weird kind of, and my stretch marks are I'm a pale person. So
yeah.
In some places they're kind of reddish, but in most places
mine are
it's
silvery.
just like this texture. Yeah, it's silvery. It's like this texture change and they're kind of reflective.
Yeah.
So they're kind of like this pretty stripy thing.
It's my zebra
I'm not
stripes.
so bothered by them anymore. Yeah. A lot of us that are majorly affected by HADs are assigned female at birth. So like we kind of don't need this unless we like remember historically or we're being assessed prepubescent. Another skin sign is atypical scarring.
Okay. That's like the scars that pop up, like a keloid scar type.
It could be keloids, but typically one term you'll see is atrophic or thin scarring, differentiated from those seen in classical EDS. So atrophic scars are those thin scars that kind of are more depressed. The skin's thinner where it's scarred over, and it has to be in 2 or more sites. And in the classic type, they have identified scarring with more severe atypical presentation, known as I can't speak.
Papricious?
Papricious. Thank you.
Is that right?
Yes, I think so.
Oh.
And or hemosiderec. Papricious is paper-like.
Okay.
You also see it referenced as cigarette paper-like.
Okay.
But a lot of us have no context for that because not as many people smoke or roll their own cigarettes.
Right. Yeah.
But so it's very paper-like thin scarring. Hemosiderec means bruise-like, very dark, looks like an injury. Yeah, and then the thickened scars, like keloid scars are seen outside of the inherited connective tissue disorders, but hypertrophic thickened scars could also.
So
here.
I'm glad you're doing again. You with the talking because I've been a wiggle worm this whole time.
Good that you're wiggling because we need that. So that's kind of what those mean. So if your scars look different than other people's, meaning the skin doesn't quite heal right, it's thinner than the skin around it. It's like doesn't seem to close as well, or it looks discolored like a bruise. And in classical EDS, it's really pronounced. I mean, it really looks like a wound. Yeah, or that scar thickening.
Okay, you really must have faith in my pronunciation of things. So what is this next thing says? It's bilateral pysogenic papules of the heels?
Good job. Okay, so on your feet.
Okay.
When you're standing up, so you're standing, you're putting pressure down on your feet like you're just normal standing up. If you see little small spheres, little globules poke through the fibrous tissue of your skin on the side of your heel, kind of like a hernia, those are little bits of fat tissue popping out through the fascia.
Well, that's really gross sounding.
It is, right?
Yes.
So these can be seen in people without EDS and can be completely benign or they could be painful.
Yeah, depending, I guess, on how they...
Yeah, both me and my daughter and both my parents have these, and we are all diagnosed.
Okay. I don't think I have these.
I actually remember staring at my mom's feet and poking them when I was a little kid.
That's funny.
I don't know what those are now. Because to me, they were just toys.
Oh.
Anyhow, sorry, Mom.
So I don't know if I have these. I'll check later. I'll have to check.
You'll have to check. So I have a video
back.
of mine.
Yeah.
One of the first videos of mine that went viral on TikTok was this, my video that I made of my heels doing this. It went viral because a lot of people have these and people were freaking out and getting mad at me and I could not handle it. And I was like, wait, what? And so like, this is one of those things that has been debated. Should this even be on the form? But it's just one of those like corroborating bits of clinical signs.
Yeah.
It does not mean you have EDS.
It's funny
that's the only sign you have.
It's funny you mentioned that because my first EDS video that went viral, the EDS in sitting, that had like 3 million views, people were like, that's normal. I sit like that. Oh, no, that's not for EDS. That means you're gay. No, that's just my neurodivergent ass. And I just wanted to laugh and laugh and laugh and laugh because, yes.
It's a...
Yes. Yes, it is.
That's funny.
Anyway, but yeah, there were people who were like, this is normal. And like, I got overwhelmed by the comments too. And thank God I found Carol Claffin, who had the 3-minute video on sitting. So I made a 1 reply video. Did you notice they took away pinning comments?
Yeah, what's the deal with that? I don't like that.
Anyway, I don't like
But
it either.
also,
But
call
I
out
found,
to our
yes.
sister Zebra. Carol is great to follow. We should link her profile. We will.
Yep.
She has some great life hacks and things she does
Yes.
to help her body along through this. That's one of the things I love about her.
But yeah, so that was really helpful because then I just was like, hey, watch this video now. And
These features seen in your skin, whether it be those little bubbles coming out of your heels or scars, your eyeball skin, whatever it is. Again, none of them on their own are definitive, but it's these collections of signs and symptoms that can help a practitioner familiar with the connective tissue disorders in diagnosis of evaluating, what particular presentation you have. And if genetic testing is unclear, can help them kind of see which box you fall in, which variant you're most like. But bottom line, more research is needed. And speaking from my own experience, my own collagen mutations are on quite a spectrum. So presentation.
mine too.
Yeah.
Okay, so so the next section is called organ features, which I'm gonna say we just talked about skin, which is an organ, but I know where you're going with this.
Internal
other organs. So now we're moving on inside, right? So you mentioned hernias just a second ago.
Yeah.
So that's, I think, the final aspect of the criteria for organ manifestations, right?
Yeah.
So one of the HEDS criteria includes specific types of hernia or prolapses. There are 2 key signs that they're looking for. Hernias are considered a sign if you've had multiple recurrent abdominal hernias, and that's when the organs or tissue is such that your intestines or stomach bulge through the abdominal wall. Sometimes this happens a lot with women after giving birth, depending on how they were cut for a C-section. They've made it better. Sometimes it can be painful and serious, but you might experience it without symptoms. Now, we're going to also mention prolapses. I know about my own prolapse. I have one. Fortunately, it's just one right now. Could you explain it though for our listeners, Linda?
You and I both have frustrating experience with this, but I'll explain it like medically what it means.
Yeah.
So you can identify this if this applies to you. So a prolapse occurs when the organs in the lowest part of your body slip down from their normal position in the pelvis due to weakening connective supportive tissue. Okay. So like all those organs are held into place and held together by these tissues, the connective tissue.
The pelvic floor.
Yeah. Gravity will affect how they sag. And if they're not well supported by strong connective tissue, they will sag and progressively change over time.
Yeah.
And weaken. So the HEDS criteria includes the following specific features with prolapse.
Okay.
Pelvic floor, rectal, and or uterine prolapse in children, men, or women that have never born or children without a history of morbid obesity or other known predisposing medical conditions. Both male and female patients with EDS and HSD can experience a wide range of urogenital and pelvic complications throughout their lifespan, and it's not widely discussed. Because some people have, a little bit of body shame about it. And it really affects quality of life. The severity and range of these symptoms does vary, but reports show the most frequent complication of this issue in EDS, JHS is with urinary complications, with over 40% of medical studies reporting one or more problems.
Wow.
If you had early incontinence, meaning unable to hold your urine, or problems with flow, or changing flow, or unable to get out your urine, particularly younger, before you had children. Also, incontinence with childbirth isn't normal either. You should have that addressed, by the way.
Yeah. They just write it off like that. Oh, well, you had kids. Okay.
No.
And
most
it's still a problem.
most health insurance in the United States covers pelvic floor physical therapy, by the way.
Yeah. I've been there.
Yep. So genitourinary malfunction in hypermobile EDS and JHS has been linked to things. These are some signs: recurring urinary tract infections, UTIs, incontinence and bladder disorders. So this doesn't mean just like you leak a little. It could be things like bladder diverticula, little bulges in your bladder, bladder outlet obstruction, bladder pain, painful urination, voiding dysfunction. And I'm going to explain to you my weird presentation. And it wasn't just young incontinence. It wasn't just, post childbirth. It was, if I bend over to brush my teeth, I will inevitably pee my pants.
Really?
And a lot of times if I sit down to pee, I can't pee.
That happens to me.
And what I've discovered, and what I found out later in life, is I was told I have a tilted uterus. So meaning the uterus is kind of squished.
Mine's tilted.
And so what happens is so all these things sagging down on it. And so it kind of pinches it off. But if I lean forward, it pushes on it and will squeeze out the urine.
That's why when I lean forward, I can go.
Yeah. And then combine that with my neurodivergent tendency to not stay hydrated. Anyhow. But so my little zebra had a lot of UTIs and it was freaking me out. Kitties. We have kitties all around us right now.
Yeah.
And that's eventually what they told us was she had bladder dysfunction. And I was like, oh my God, is somebody hurting my baby? Because that is a sign of well, this is going to be on the podcast, so that's a sign of sexual abuse and sexual assault. And I was like, I'm around at the time, surely they're not doing this at daycare. I would go at lunch and have lunch with her, and they were amazing.
Yeah.
And I had her checked, and there was no sign of that, no other emotional or behavioral sign either. It was just it actually made she potty trained late, despite having the complete intellectual ability. And so little signs like that in neurodevelopmental, so young children signs, but also as a teenager having these little signs of bladder dysfunction. So what about you? Do you have?
I always had to go. I could never hold it. I was always a frequent peer before I had children. It only got worse after. My bladder prolapsed during childbirth. So
mine,
I went home with a cath bag. I went home with a Foley in.
My ureter ripped.
Oh, Jesus.
There's your sign.
Yeah. So yeah, my bladder prolapsed during childbirth, and it was never really right before, and it definitely hasn't been the same since.
Not right since, yeah.
Yeah.
Yeah, fun times. And so that's something that we have some shame on.
Yeah.
Of course. Is it and I remember helping my grandmother through that and stuff. But so also your health insurance can cover disposable supplies for that too, by the way.
Yeah.
There's another life hack. Talk to your doctor about it. A lot of us don't. A lot of women don't. I didn't until,
I didn't until it got really, really,
really.
I mean, it had been affecting my life for so many years.
Yeah, you just
that I was just used to it. But it did. It got to the point where I couldn't let it affect me anymore because it was just getting worse. So.
Right. So what do you think the second most affected domain of pelvic organ dysfunction in EDS and JHS is?
If I had to guess, I would say probably the uterus.
Yeah, gynecological concerns. Yeah. So again, the manifestations are wide-ranging and symptoms vary. The zebras experience this at all different kinds of levels. Okay, it's not just one thing. But there are some trends seen in reviews of research and case studies. So POP, pelvic organ prolapse, is unfortunately very common. It's not just a matter of like discomfort, but may include menstrual complications with pelvic floor dysfunction, additional pain in the area, can cause sexual dysfunction, and just pain complications. The organ differences can affect fertility, pregnancy, childbirth, menstruation, all those things those of us who have a uterus deal with. It also will affect your doctor's approach in managing any of those conditions. Like a lot of times they will suggest we treat things like endometriosis with organ removal or partial removal, but for example, they may hesitate to do that if you are an EDS patient because removing an organ will create more problems because there's a bigger void.
And that goes the same with removing of teeth. They try to avoid it because it causes other. Yep.
So another embarrassing and doesn't have to be manifestation of prolapse is in the lower gastrointestinal or GI tract. We can present with rectal prolapses. So we may experience either fecal incontinence or constipation, and both can be very uncomfortable. You may get hemorrhoids and all the fun things that go with that. It's really important to treat that. Don't be ashamed to bring that up to your doctor for assistance. Probiotics, fiber, a healthy diet can all help you manage. It doesn't mean you have to have surgery, but if you let it get bad enough, it may require surgical intervention, and that is a very hard thing to live with.
Yeah, and it doesn't always take well, or the complications after, because of how our body builds collagen in response to healing from the surgery.
Exactly. And in males, they have external genitalia, and that can be affected by prolapse tendency into their pelvic organs as well. Okay. And that can be excruciating painful.
So my friend's son was born with hypospidasis. That's common in EDS, right?
That is an example of
She's a zebra. She's a zebra.
Of the presentation. So the complexity of hypermobile anatomy should be considered. For example, an organ prolapse and associated pain can be connected to impaired joints of the pelvis. A lot of us have difficulty with our sacroiliac or SI joint. I do. Our low back, our coccyx, tailbone, our hips. The whole pelvis tends to be a little wonky. Additionally, these joint issues frequently present with weakening and or tightening of muscles in the lower back, the hips, the pelvic floor. A lot of times our pelvic floor therapy doesn't need to be focused on strengthening. It needs to be focused on relaxation.
Yes.
Which is what I learned. These tissues can experience severe pain disorders, such as heightened or dull sensitivity. And obviously that affects other sexual things. But so organ manifestations of hypermobility and connective tissue disorders are quite wide ranging. That's what we've said. It's all your organs, externally and internal. But only 2 features are specific on the HEADS hypermobile EDS criteria currently. Additionally, the research shows that these types of issues present in other types of EDS as well. So these signs are really not exclusionary. It's just, again, we're building a stack of symptoms, not just one. Okay. None of these features alone are really necessarily able to determine an EDS diagnosis. This is why it's so important to be evaluated by a physician that can put together all the pieces of the puzzle. The next part of the checklist that they use will help identify if your presentation should be considered genetic or inherited.
Oh. Yeah. So this really just kind of all the doctors who think it's just a bendy problem, a joint problem. These organ issues can be just as debilitating, if not more so, and as far as affecting quality of life, than just having like screwed up hands and knees and elbows, Yeah.
This is really one of the most frustrating misconceptions and forgotten aspects of EDS.
So it's not just the joints. I am the joints. That's me. But I don't really roll them because of these hands. So What we finished Criterion A part 2. Where are we?
Okay,
What's
so we
next?
just went through
I'm sorry,
part
feature
2,
A.
feature A. Yeah.
Part 2, feature A of
That was just
Criterion 2.
A.
That was just A. How many of the things in A do you have to have? Just one of those things, maybe?
To qualify. That's a weird word. No, so to meet.
To be eligible for this cash and prizes. Sorry. Okay, sorry.
No. So to meet the criterion for 2A, you have to check off the box for at least 5 of those things.
And there were 12, so you have to have. Okay.
Yeah.
So tally up your score, everybody.
So we move on through the alphabet. So 2B.
Okay, so what is in the section of 2B or not?
Okay. So once your physician has evaluated your presentation and history in the feature A section, they will then use your family history to determine if this is an inherited condition. So you're positive for feature B of criterion 2 if you have positive family history, meaning one or more of a first degree relative, somebody you're blood related to, independently meets the current criteria for HETs.
Well, that sounds pretty easy. Is that you just check a box?
Yeah. So it's just one checkbox. Yeah, but it's an important piece of the puzzle, right? Yeah.
Yeah. Okay. Well, I mean, I guess if it's in your family, that leads to say, oh, this is probably a genetic thing, which is when they decide if they're going to genetically test you. So,
yeah.
What?
So that's why it's so important we say to, do your homework and get all your ducks in a row. Unfortunately, though, not everyone has access to family history. That can be a privilege.
Yeah.
But if you can get this information, it's vital in help determining the likelihood of this being inherited. Yeah.
Okay. So cool. So now
so
we're on to
next letter in the alphabet
is C.
Criteria 2, feature C.
All right.
So you may also have some limitations in expressing the next part of the criterion. To meet the final feature of criterion 2, your doctor will discuss your symptoms related to pain and joint instability.
Okay, so if you're struggling with expressing yourself or if you have progressed stiffness, you might not be able to exactly articulate pain, or you may not even realize what you are experiencing as pain because you've always had it. And the level of instability in your joints, because you're older, might be different. So just what?
Yeah, so think through these questions before you go write it out or something.
Yeah, write it out.
This is another reason why we encourage you to go through these criteria and prepare before your evaluation. So for this part, you must check off at least one of these 3 boxes in criterion 2, feature C, which includes, so this is the first one of 3. Remember, you have to do how many?
1.
Just 1, okay? To do any of these apply. Musculoskeletal pain in 2 or more limbs, recurring daily for at least 3 months.
Yeah.
Okay. Chronic widespread pain for greater than or equal to 3 months.
Also true.
Recurrent joint dislocations or frank joint instability in the absence of trauma.
Yeah.
Okay. So musculoskeletal pain simply means pain in your muscles or bones. Joint instability up to dislocation can present as your joints feeling overly stretched beyond the normal range of movement and feeling unsupportive or out of socket. We not even realize that you have dislocated.
Correct. I did not know for the longest time, and I'm going to have you explain it. Explain, because I was dislocating, subluxing way more than I thought I was.
Okay, no, me too.
So what is it? What are some examples?
So every time I carry groceries, my finger, I don't know that I can show it or should, my fingers pull apart the joints. And my elbows do. Yeah. So here are some examples. Rolling ankles, popping, crunching, grinding sounds,
Mhm.
nerve pinching, pain, numbness, difficulty sleeping and waking up with more pain than when you went to sleep.
I must have
Neck,
slept weird.
hip, spine, hips being hyperextended while you sleep.
Yeah.
Standing up and feeling like you're about to fall over because something is out of place. Difficulty with carrying things or hyperextension or stretching out of joint from weight or normal force, what would be normal to other people. Migraines from neck
Fucked up my
instability.
shoulder just closing windows.
Yeah.
Like
Yeah. Migraines from neck instability. That's probably one of the most life-altering things that my kiddo deals with. Difficulty sitting, standing, walking, running, lifting things. Difficulty writing, taking school notes, carrying things in your hands.
difficulty mousing. I actually have a vertical mouse here that
Difficulty
I will.
typing. Yeah. This is not an all-inclusive list. I just,
No.
I'm
But those
rattling
are
off
things you
we've
don't think
experienced.
of. Like I didn't realize when I was walking around or if I moved and shifted and I heard this like that.
Yeah,
It didn't feel great, but it wasn't like it just happens to me all the time.
Biting down on an almond in your jaw, feeling like it went out of place. Oh no, it didn't feel like it went out of place. That pop, that grinding noise, and then you having to put it back where it goes. That dislocation or sublux.
Yeah. When you have to like, my elbow would get locked up until I did a and like reset it. Oh, I knew obvious ones when my knee went out. Like when my knee went out when I was a kid, that's freaking obvious. And I just went whack and stuck it back in. And then it was a weird story.
Or the funny ones we just do as jokes, whatever.
Right. But like the little, like I didn't realize. Oh,
I did not know all these shoulder things were like me popping. Like my dad taught me how to put my shoulder back in. I did not know that was like, because it was just
that's something we did.
I'd experienced since childhood. I did not associate with or know it as a dislocation.
Yeah.
Like that didn't like it. That seemed like a medical emergency to me, and to me, it was just a daily frustration.
Yeah.
And like saying it out loud, I now realize how slightly insane it sounds.
So you just have to have one of those things? One.
That's why I said, okay, now how many of those? Just one. No, this is the definition of my whole life experience, right?
Right. Yeah. 100%. Okay. So
that was easy.
That was easy. And that's the end of this bit.
Yeah, that was a lot. So thank you guys for listening and working through the HEADS criteria worksheet with us. So what's next, Shelley? You're in charge.
Oh, just the way I like it. You know what? We've talked a lot about hypermobility, but we haven't really talked much about the things that go with it. So what if we take a break from this hypermobility stuff? What do you think?
What do you want to talk about next then?
Well, we touched on it a little bit. What about neurodivergence?
That's a great idea. That's
why I thought of it.
Yeah. We can take a poll on our TikTok and post it on our website. Do you guys want to talk about ADHD or autism spectrum disorder? You guys vote and let us know.
Yeah, we'll post it on our website.
It's Shelley. I'm editing, and what we decided to do was split this episode into two. So this episode is just going to be about Criterion 2, features A, B, and C. Next episode is going to be all about Criterion 3, and then we will do the neurodivergent topic. We are entering a busy time of year, and Luna and I just wanted to kind of keep content going, but also keep ourselves centered. So there you go. Also, you may, if you listen to the next episode on Criterion 3, you will see that this ending is going to be the same, some of it, because we recycled it. Okay, bye.
Yeah. So thank you for listening to the Hacking Hypermobility podcast.
We would really appreciate it if you would take just a minute to share, follow, or leave us a review. It helps us grow the podcast and spread awareness.
Yeah. Our little TikTok's growing. We're almost at 500 followers. Did you see?
I checked. It was 444, which is a special number to me.
And 4 is my favorite number. Oh, I love it.
That's great.
Yeah. Well, we're going to wish you a healthy hypermobility. Have a happy day, zebras.
Bye, zebras.